like to thank the director to invite me to participate in this meeting. You will know that for effective and safe left appendage occlusion procedure, we need a detailed knowledge of the left-sided appendage, the left atrial, and the neighboring structures that are surrounding the orifice of the left-sided appendage. There are a marked variability in the anatomy, in the gross morphological feature of the left atrium and the endocardial aspect of the left atrium and the areas of the left-sided appendage. Here you can see this is the left superior pulmonary vein, the right superior, the left-sided appendage, and the close anatomic proximity between this left-sided appendage and the pulmonary trunk. The left-sided appendage is the more anterior structure of the left atrium. And all this area correspond to the transverse sinus of pericardium. It is important to identify the transverse sinus of pericardium during the transeptal punctions. Here, you see the left-sided appendage, and we are going to see how the morphology and how the muscular tissue in this area is not uniform. This is the orifice of the left-sided appendage, this is the tip of the left-sided appendage, and this area corresponds to the transverse sinus of pericardium. This is the oblique sinus of pericardium. Therefore, the left-sided appendage, the anatomic relation with the transverse sinus of pericardium and with the oblique sinus of pericardium. We can divide the left atrium in 4 components. The septum, that is the septum is only the fossa ovalis, as you well know, because superiorly and inferiorly is the fall of the left atrium, and transeptal punction through this area, and through this area we go out of the heart and inside of the heart at the disaster. This is the fossa ovalis, and here you can see in this thoraxis, this is the mitral valve, this is the vestibule of the mitral valve, and the orifice of the left-sided appendage. Here you can see the right-sided appendage and the difference between the attachment of the pectinate muscle of the right atrial appendage versus the left-sided appendage. In the left-sided, most of the appendage of the pectinate muscle are inside of the left-sided appendage. Here you see therefore the 4 components: the septum, the venous component, the appendage, and the vestibule. The venous component is the major part of the left atrium, and a narrow mouth marks the junction between the orifice of the left-sided appendage and the venous component. This is the left side of the fossa ovalis, this is the left superior pulmonary vein, the left inferior pulmonary vein, and the vestibule of entrance to the mitral valve. Here you can see the close anatomic proximity between the right inferior pulmonary vein and the right superior pulmonary vein with the left-sided aspect of the fossa ovalis. What are the determinants of the left atrium during the procedure? The dimension of the left atrium for the device, the thickness of the left atrium. We are going to see that the anterior wall and the veno-atrial junction may be very thin. The distance from the fossa ovalis to the left-sided appendage, ostium for all devices, and the interatrial septum should be a low posterior transeptal punction, the dimension of the fossa ovalis, the thickness of the ring of the fossa ovalis, the proximity to the aortic root, and the presence of occluder device, septal aneurysm of patches. Here you can see the non-uniform myocardial thickness of the left atrium. Here the epicardium has been removed, and this is the myocardial tissue of the left atrium. Please note the absence of muscle in this area, very close to the left-sided appendage and to the left superior pulmonary vein. The distance from the fossa ovalis to the orifice of the left-sided appendage is an important anatomic determinant, and here you can see the anatomy of this ring that is also an important anatomic determinant during transeptal punction for left atrial appendage occlusion. Here you see this aneurysm in the left-sided aspect of the fossa ovalis. This is the fossa ovalis, septum secundum, forming this aneurysm in the left atrium. Please note all these endocardial trabeculation in the left atrium. The left atrium is not as smooth as usually we believe. Please note all these trabeculation, and this is the orifice of the left atrial appendage. The left atrial appendage can be seen here. Please note the transverse sign of pericardium. This is the right atrial appendage, the superior and inferior vena cava. And we are going to see the marked variability in the epicardial aspect of the left atrial appendage. Here, please note these 5 different appendage. There are different orientation of the tip of the appendage and different morphology in terms of orientation, in terms of its anatomic relation with the pulmonary trunk, and in terms of number of lobes. Here you can see appendage with 1 lobe, 3 lobes, and the major part arc with 2 lobes can be seen here, 54%, this appendix with 4 lobes. This image is just to show the marked variability in the morphology of the appendage that we need to take into account during the procedure. Please note, this is an accessory appendage, different morphology, and the presence of this accessory appendage we should take into account when we consider that everything is close in terms of anticoagulation. Please note that this appendage is here. In this study, you can see the orientation of the appendage superiorly and parallel to the pulmonary artery. The tip in this type 2 is inferiorly and parallel to the pulmonary artery, therefore different orientation of the tip of the appendage. And here the appendage is superiorly, but between the pulmonary artery and the body of the left atrium. Therefore, 3 different orientations of the appendage. It has been related, the morphology of the appendage, with the risk of a stroke. And it was defined different morphologies of the appendage, being these 3 morphologies with an increasing risk of a stroke for patients with thromboembolism. The endocardial aspect of the left atrium can be seen here, and this slide is just to show the marked variability of this endocardial aspect. Please note the left inferior, the left atrial appendage, the close proximity of the circumflex artery to the orifice, and here on this heart, human postmortem heart, you can see the left superior, the windshock aspect of the orifice of the left atrial appendage, and the presence of this lateral crest in the left atrium, between the left superior and the orifice of the left atrial appendage. Therefore, the presence of this lateral crest, one important anatomic determinant. Second, please note here, the pectinate muscle. Not always the pectinate muscle are inside the left atrial appendage. They are the presence of this extra-appendicular pectinate muscle arising in the orifice of the left atrial appendage. And this is also an important anatomic determinant. The ostium of the appendage. You will know that it's very important to consider the size of the left atrial appendage for left atrial appendage occlusion. More are oval shape, but in some they are round form, round shape. Different size, different form, more elliptic, more round, that are very important when we are planning the occlusion of the left atrial appendage orifice. The volume can be seen here from 0.7 to 90 milliliters. The orifice, the diameter of the orifice can be seen here with the range between 5 to 27 millimeters, and the length of the appendage with the range between 16 to 51. In this endocardial aspect, you can see the orifice of the left atrial appendage, the presence of the lateral crest, and the diameter, the larger and the shorter diameter of the orifice of the left atrial appendage, with a range between 10 to 24, the larger, the longer, the shorter, with a range between 5 to 20 millimeters, and also the distance between the left atrial appendage and the left superior pulmonary vein, that in some heart may be 6 millimeters, with a range between 6 to 24 millimeters. That is also an important anatomic determinant. And the length of the vestibule, the entrance, the vestibule of entrance to the orifice of the left atrial appendage, with a range between 5 to 15 millimeters. Here you can see the pectinate muscle, thickness 1 millimeter, with a range between 0.4 to 1.5, and the width with a mean of 3.6 millimeters. Here you see the left atrial appendage and the orifice of the left atrial appendage, the pectinate muscle. Please note the tissue in between the pectinate muscle, and the extra-appendicular pectinate muscle can be seen here. And I think this is also an important anatomic determinant when we are planning the occlusion of the appendage. Can be seen in 28% of the heart. You see here the ridge, the appendage, the pectinate muscle, and please note in this histological section from Professor Sanchez Quintana, and note please the absence of muscle. This is the pectinate muscle. This is the vestibule of entrance to the mitral valve, and the proximity to the circumflex artery in this area. This is the area leading the ostium of the left atrial appendage, the limbus of the left atrial appendage. And the area leading the ostium of the left atrial appendage is also variable. This endocardial aspect is also variable, also an important anatomic determinant. This is the vestibule of the mitral valve, and the area leading. This limbus has been studied by the group of Dr. Lopez-Minguez, and you can see the orifice of the left atrial appendage, and this is the area marked between the left lateral ridge and the vestibule of the mitral valve, the limbus of entrance to the orifice of the left atrial appendage. The limbus corresponds to this area. Here you can see the bundle. This is the left lateral ridge, and this is the orifice of the left superior pulmonary vein. This is the orifice of the left atrial appendage, and the ridge. As can be seen here, the ridge is not a ridge. It's just a fold of the lateral wall of the left atrium. This is not a ridge, in fact. Here you see the left superior. This is the orifice of the left atrial appendage, and the fold of the lateral wall of the left atrium, extending from superior to inferior and from anterior to posterior, the ridge of the left atrium. Here you can see the ridge, left superior, from superior to inferior, and the left superior pulmonary vein, the vestibule of entrance to the mitral valve, and the orifice of the left atrial appendage. Here you can see the anatomic relation between the orifice of the left atrial appendage and the left superior pulmonary vein that has been also studied by Lopez-Minguez, and you can see the left superior that in some patients is not at the same level, the left atrial appendage, the left superior pulmonary vein, marking by this ridge. Therefore, also, the variable orientation of the left atrial appendage in relation with this anatomic fold of the left atrium, with this ridge, can be also an important anatomic determinant. The muscle of the appendage, the muscle of the left atrium. Here you see the Bachmann bundle, superior vena cava, left pulmonary vein, right pulmonary vein, the orifice of the left atrial appendage, epicardially, and here endocardially in C and D. Here the left atrium has been everted, and this is the endocardium the endocardium has been removed, and here the epicardium has been removed. Please note the Bachmann bundle surrounding the left-atrial appendage. The left word extension of the Bachmann bundle can be seen here. This is the left-atrial appendage. This is the area of the Marshall vein. And this is the epicardial aspect of the ridge. This is the left-atrial appendage, and the epicardial aspect of the ridge is this area. Indeed, this is the ridge that corresponds to the septoatrial bundle that surround endocardially the left atrial appendage. Therefore, the muscle of the left atrial appendage endocardially the septoatrial bundle, and epicardially the left ward extension of the Bachmann bundle, endocardially, and the muscle epicardially. Please note this slide. Here you can see the myocardial thickness of the appendage. This is anterior, and this is posterior. In most of the heart, the posterior aspect of this appendage is thinner when we compare with the anterior aspect. Therefore, a thinner aspect of the posterior wall of the left atrium. Here, this is 10 millimeter. Please note that this is 1 millimeter or less. And in some cases, they are absent of muscle, as can be seen here. This is the orifice of the left atrial appendage from an epicardial point of view. Therefore, the left atrial appendage, we should take into account different anatomic determinants. The morphological variants, it is important to consider that the left atrial appendage is directed behind the pulmonary trunk for the lariat. The ostial diameter and the circumference is important. Consider this range for the watchman and for the unpluster. The length of the left atrial appendage, the width, that should exceed the maximal ostial diameter for the watchman. The angulation of the left atrial appendage is also important for all devices. Less able to be angled, especially concerned for the watchman. The maximal length of the dominant lobe for all devices is important. The multi-lobe appendage oriented in different planes may be exclusion criteria for the lariat. The distance from the ostium to the first bend of the left atrial appendage, you know that is very important to measure the landing zone that should exceed the maximal ostial diameter for the watchman, or the landing zone more than 10 millimeters for the unpluster. Trabeculation, the presence of this trabeculation, the pectinate muscle, that sometimes it's difficult to establish the diagnosis, the differential diagnosis with the thrombus, the thickness, the presence of this extra-appendicular trabeculation, the risk of cardiac perforation, and periprothetic leaks. Some periprothetic leaks may be anatomically determined by this extra-appendicular trabeculation, the diameter of the left superior pulmonary vein ostium, the relation between the left superior pulmonary vein and the orifice of the left atrial appendage, that usually are at the same level, the orientation and width of the ridge, and the presence of the thrombus. But what are the anatomic relations of the left atrial appendage with the neighboring structure? Here you see the left atrial appendage, and this is the more important anatomic relation with the circumflex artery. Here you see the aorta, and the aorta, the orifice of the left atrial appendage, and the presence of this close anatomic proximity with the circumflex artery. This is the left coronary sinus, the orifice of the left atrial appendage. And please note here in this slide the sinus-nodal artery. The sinus-nodal artery in 25–30% of the cases may arise from the circumflex artery and close the anterior aspect of both the left atrium and the right atrium through the Bachmann bundle. Therefore, the sinus-nodal artery, the base of the left atrial appendage, is in close anatomic relation with this sinus-nodal artery. We are able to identify the circumflex when we are measuring or determining the landing zone during the procedure. Here you see the sinus-nodal artery, this is the left atrial appendage, and this is the left superior pulmonary vein, this, the circumflex and the sinus-nodal artery here. This is the epicardial aspect of the ridge. Please note here, this is the left superior pulmonary vein, this is the appendage, and the sinus-nodal artery. Some cases, it's also important, the presence of these, the persistent left superior vena cava can be seen here. Also, here you can see the circumflex, the appendage. We are able to identify using imaging technique, but also please note here the left phrenic nerve. This is the orifice of the left atrial appendage. The non-uniform myocardial thickness of the left atrial appendage, the close proximity of the left circumflex artery, but also the left phrenic nerve. The left phrenic nerve may also be in close anatomic relationship with the orifice of the left atrial appendage. Here you can see the left phrenic nerve and the distance from the left phrenic nerve to the orifice of the appendage. And this is the fibrous pericardium. This is the endocardium, the myocardial tissue, and in some cases may be with the range from 2.5 or 1.5 from the left phrenic nerve to the left atrial appendage. Therefore, the presence of the left circumflex artery, the risk for artery compression between the anchorae lobe and the disc for the amplacer, the artery of the sinus node, the presence of the great cardiac vein and obtuse marginal vein, the presence in some cases of the persistent left superior vena cava, the pericardium, and the left phrenic nerve of special concern for the laryngx are anatomic determinants that we should also take into account when we are planning left atrial appendage occlusion. Therefore, there are important gross morphological aspect and endocardial aspect of the left atrium, the left atrial appendage, and the neighboring structures. We should take in our mind the non-uniform myocardial thickness of the left atrium. In some areas of the left atrium, they are absent of muscle. They are just connective tissue. And some areas that are very close to the orifice of the left atrial appendage. Thank you very much for your attention.